where are we in terms of meeting the budget language? The innovations I've begun to mention. We have the new managed care contract. The Behavioral Health Service Administrator is on board and will be starting up in November. Commonwealth Coordinated Care is the dual eligible program, barring any legal misadventures. We hope to have that up in January. And I say legal misadventures is procurement in our space is very difficult, and every little thing can create a challenge and a delay. We are transitioning populations still in fee-for-service into managed care for basic health services, and then long-term we have to look at building on experience gained in the duals project, look at transitioning the remaining long-term care. You've seen this slide before. We are working regularly with CMS to implement reforms. Again, the top three boxes I think we've checked. We have asked for some additional flexibility in terms of doing pilot and innovation projects. Cindy Jones sent a letter to Cindy Mann at CMS last Thursday or Friday, which is now posted on the CMS website, which outlines and can show you clearly what our ask is of them around giving us flexibility. Remember, the idea here is that when we do have a program in Virginia, such as DCC across the street at VCU, that does appear to work with high utilizers of healthcare, can we do things like mandate that individuals go into a particular plan that might actually benefit them, that shows lower costs? That would be an example of something we know that works, and we'd like to have permission in advance to begin to do some of those things around the state. The key questions here in terms of waivers, when we ask for a waiver for the state from the Medicaid requirements nationally, what we are trying to work through is what can we do with authority that we have currently, and then what do we need to get additional authority for. I also will have, or I think Cindy has posted on the DMAS site, a very good summary, a white paper that implementing Medicaid reform in Virginia, which walks us through the purpose of the program, an overview, our existing authorities, where we're looking for the reform, particularly, and some of the next steps. So let's go to the scorecard. Phase 1 reforms, remember that's continuing what we're already doing. And we've got a lot of green here, dual eligibles, on track, program integrity. I have a long list of things. I get weekly project reports from Lois Healy at DMAS and others. They're all walking through the technology we're using to look at data, the contracts that are out and so forth to ensure that our taxpayer dollars are being spent wisely. The foster care enrollment for these kids will be complete by the spring of 2014. We were slower than we would like. It took some a while to actually locate proper addresses for some of these kids and match them into the plans. The eligibility enrollment system, we're calling it green. Delegate Massey is on or about October 1st. We were out running the bear. The access to veterans benefits, this is very deliberate effort to ensure that those who have served are actually getting connected with the VA when that is the more appropriate place for them to get their insurance. And then we, of course, continue to look at the Medicaid-funded behavioral health services. And Magellan is now staffing up here in Virginia to do our coordination of care there. Stage 2 reforms, commercial life benefit package. I think that's yellow up there. What I will tell you that we're working with is we already, for most of the people in acute health care, do have a commercial life benefit package. The question here is getting permission and so forth to modify the program around service limits, et cetera. The other issues is we try to encourage cost sharing and wellness. That we look, how do you encourage a beneficiary where by law, and Dr. Smith was, I think, a little, when you spoke about the beneficiary cost sharing, it's not that CMS has flexibility for individuals below 100%. That's in statute, so they can only give us flexibility above that. Otherwise, Congress would have to act. And I don't think anybody's expecting Congress to act for years, but on anything, unfortunately. But that being said, how do you then incent people? And that's where you look at things like savings accounts or cards where they get something that they keep if they spend it appropriately. That's some of the innovation we're looking at. We are looking at limited provider networks and using more medical homes. Again, that's something that we're seeing in the commercial space. We have quality payment, that's green, I've already mentioned that to you, and we are in process on the innovation. Dual eligible project, green, the IDED waiver redesign. We promised this as part of our DOJ discussions and the need to do a better job of looking at needs as opposed to diagnosis in this space. Contractors are on board and are working through the process around the waiver redesign. Hard to know how much we'll have for you to look at budget-wise this year, but that is coming. We're looking at bringing all home community-based waiver enrollees into managed care for the medical piece next October. Then the PACE programs, which we do very well with in Virginia, are going to be expanded in July of 15. It takes a little while to get through those, and right now our staff is tapped out on more version business. Then the stage 3 reforms, the all-inclusive care for the home community-based waivers, and finishing the Medicare, Medicaid dual project will take into the 2016-2018 timeframe most likely. As we build on the experience we have, you have to start with something, ensure that it works, then take the time to roll it out. I believe these slides you've already seen. I've already mentioned the marketplace navigator.